Um, First, before I start, I actually want to congratulate all of you guys. I have never been to this program, but it's amazing. Like, you guys being here at this hour of the day, wants to learn about healthcare, wants to learn about all these new innovations that are happening. It's just amazing, like, that what you guys are doing, and it's amazing that Dr. Mal is doing all that, and having you guys here and getting us to explain and educate you on things. It's just an amazing program. Congratulations, everyone. So let's talk about this. That what it is. So it's transcatheter aortic valve intervention. So from the name, you can kind of guess that it's transcatheter. So something has to be with catheters. Catheters, we use a general term for plastic tubes, or like the synthetically made tubes that we use to intervene on different parts of the body. So it's not an open heart surgery, but we do it with a catheter that most of the time is inserted through the groins. Sometimes we insert through the arm, and very, very rarely now, we do insert directly into the heart, making a small incision. But most of the cases in today's age, we can do it through the groin. So I will walk you through, what it is and who is the candidate and what it's all about. So in short terms, I don't know, some of you guys might have heard these terms TAVI or TAVR. If not, it's fairly new, don't feel bad. Actually,
push back text again.
Sure. Okay, that's better probably, yes. So some of you guys might have heard these terms TAVR or TAVI. If not, don't feel bad because it's fairly new. We started this journey as interventional cardiologist community about 10 years ago when it was in trials, and after a few years it became available commercially. The way we started was there were certain patients, most of them were old and with a lot of medical problems, that they had the disease but they were not open heart surgery candidates. So then this technique came in and we were like, let's do it on them and give them a chance. A lot of patients benefited. Then we're like, oh, it sounds cool. Can you do this that was being done with open heart surgery? Let's now just improve. So slowly, I will tell you where we are today. So first, let's understand. So these terms, if you did not hear, you will hear about them today. So transcatheter aortic valve replacement, called TAVR. Transcatheter aortic valve intervention, that means something is being done to the valve that may not be replacement. And then the alternate term some people use may not be accurate, but they say, oh, minimally invasive. What that means is that we're not going to cut the chest open and we're going to be minimally invasive and just do this procedure, but that term may not be accurate. But let me tell you, so Dr. Slotweiner did a great job explaining the chambers of the heart and the valves and all that. I'll just walk you guys through quickly. So right upper chamber, right lower chamber. Left upper chamber, left lower chamber. So there are how many chambers in the heart? Four. So how many valves there should be in the heart to keep the flow in one direction? Same answer, 4. So yes, there are 4 valves. So one is here, that's between right upper and right lower chamber of the heart, called tricuspid. You don't need to remember the names. There is one, these big chambers, one is inflow and one is outflow, just to make it easier. So this valve, making sure blood comes in and doesn't go back. And this valve here, making sure blood go out of this big chamber and does not come back. Same idea on the left side. It's not that hard. Left upper chamber, left lower chamber. There is a valve in between that makes sure when this big chamber squeezes, blood does not go back. And so the blood comes in through this valve, go to the body. This big vessel is called aorta. At the base of this aorta, there is a valve here that we are talking about today. This is called aortic valve. Just so transcatheter aortic valve, that means this procedure has to do something with this valve. So what happens with this valve? So here is another section of the heart that you can see, left upper chamber, left lower chamber, and from there blood goes into the body, and this is being guarded by this aortic valve. And this valve makes sure that the blood does not go back into the chamber, and that ensures the blood is in one direction. That's the job of these valves, to make sure that blood goes into one direction and does not go back. So these valves are doing wonderful job for us, but then with aging, most of the time there starts to become a problem. Not for everyone, but there are certain people who are patients of this disease where what happens is, let's say if this valve normally opens, it looks like this. This is an open valve. It has 3 cusps, 1, 2, and 3. When it closes, it looks like that. And when it closes, the blood does not go back because it's closed. But what happens most of the time, if patient has 3 cusps in their 70s or 80s or 90s, they start developing this narrowing. So if you look here, this valve is open. Doesn't seem like it's open, but apparently it is open, but it's a diseased valve. So the diseased valve cannot open like this, but it's opening like this. And when it closes, it looks something like that. You see there's a little gap in there. So because of that gap, the blood is gonna go back, and because of this narrowing, not a lot of blood is gonna go into the body. So that becomes a problem, because your body is not getting enough blood because this valve is tight. And this condition is called aortic stenosis, aortic valve stenosis. So this patient has developed that. So now, what are the symptoms? Symptoms are very similar to the blockages in the blood vessels of the heart. The coronary arteries, we know about them, I believe. Those are the arteries that you do bypass for, or you put stents in. So the symptoms that you get from those coronary arteries are very similar to the symptoms that you get from aortic valve stenosis. So what are those symptoms? You could have chest discomfort while you walk. It's the same symptom that you get when you have a blockage in one of the blood vessels or more. And it's usually predictable. You know it, that you're going to walk 2 blocks and you're going to start feeling chest pain. It's very predictable usually. You could have shortness of breath, again, predictable. You walk 1 block, you have shortness of breath, and you know it's going to come again once you walk. So it's very similar to coronary artery blockage. Sometimes people pass out. That's usually not the case in coronary artery disease, but it is the case with the valve. The patient just pass out, and usually it's exertional. You started walking, you walked 1 block, you didn't feel good, you may pass out. That is due to aortic stenosis. Sometimes it's very vague and patients are just tired. They just are tired. They don't feel well because body is not getting enough blood because of that tight valve. And very rarely, but sudden cardiac death is one of the symptoms of this problem, that patients just can die suddenly because of this disease. Okay, so again, these symptoms are very similar to coronary blockages. And why is that? Just try to understand this. Just ignore this valve. I know it's there, but just imagine it's not there, and I couldn't get a better picture that can explain this valve. So here is the pumping chamber of the heart. Here is the big vessel that supplies blood to the heart. Now, let's say if this valve is blocked, it's the same thing if you have a blockage here, and that's the coronary artery. So idea is the same, that that your heart is not gonna get enough blood, and that's why you are going to have chest pain or shortness of breath or fatigue, or you may pass out. The patients who have it, I mean. So this is aortic valve and coronary artery disease correlation. So how do we know? So let's say if someone is having chest pain or shortness of breath or is fatigued or is passing out, how do we know that you have aortic valve stenosis? Again, you need an evaluation by your doctor who will hear your heart out and will probably hear an abnormal sound that will make him think, aha, this patient might have a valvular problem. So you will be sent to a cardiologist who will evaluate you and most likely will order a test called Transthoracic Echocardiogram. I'm sure almost, how many of you had a Transthoracic Echocardiogram or an ultrasound of the heart? Anyone had an ultrasound of the heart? No, some not, but some did. Yes. So you might remember that the technician takes a little gel, put it on a probe right here, and put it on your chest and try to see your valve. This is called transthoracic. It's outside the thoracic cavity, so transthoracic echocardiogram. So how do we know that there is a problem with the aortic valve? We use the same concept. You guys know that if you have a pipe and a hose and if you just pin it or pinch it, you see the flow just increases, the velocity increases and the water goes farther away. So we know this concept and we use the same concept that if your aortic valve is tight, the velocity of the blood across is going to be higher. So that's how we know that there is a tightness and there is a problem. So that's one test. We may need a second test called transesophageal echocardiogram. What this is that you put an ultrasound probe in your food pipe. Patients are sleepy. We don't like to do it on awake patients. It's not very comfortable. So we put an ultrasound probe through the mouth into the food pipe, and our food pipe is in almost direct contact with the heart. So we look at the heart more closely and study. That's the second way. Then there is a third way, that is cardiac catheterization. What we do is we put our catheter through the groin all the way up to the heart and just measure pressure in the heart and outside and see how much is the difference. That tells us there is a blockage. So there are different ways to diagnose it. So how do we treat? If a patient has a aortic valve stenosis, that means they have a tight aortic valve, what we do? It's a mechanical problem. The problem is with the mechanics. The valve is not opening wide, so it's a mechanical problem. For the mechanical problem, usually the treatment is something mechanical. Medications may help you, but they don't really resolve the issue. So the first treatment option, one of the options, now I should say things have changed, is open heart surgery. That a surgeon will open your chest, dissect the old diseased valve out, put a new valve in, sew it in, and close your chest. And now you have a new valve. There are two types of valve. One we call it bioprosthetic, and other are mechanical. They are made up of metals. So there are two types that surgeons can put based on a condition and patient's age and other factors. So now that's one treatment option, and that's been going on for a while. And the second treatment option is TAVI, Transthoracic Aortic Valve Intervention, or TAVR, Transthoracic Aortic Valve Replacement, that I'm going to explain a little bit what it is and how it's done. And then the medications, as I said, they may help patients with the breathing, but they may not resolve the main problem. That is a mechanical problem and needs a mechanical solution. And then palliative care. So here is open heart surgery being done. If you feel like vomiting, let me know, I'll just skip. So here is the chest being open, and here is a heart right there, and what surgeon is trying to do is taking the valve out and putting a new valve in, and then trying to solve the problem. But it's a big surgery, leave a big scar. There are complications associated with this big surgery. I'm not saying it's bad surgery, because still it helps a lot of patients. It does. And still in the future there are going to be some patients who will be candidates for this and not the transthoracic therapy. So that's open heart surgery. And here is the TAVI or TAVR being done. So you see, like, all you have is a little tiny, like, plastic tube in the groin. It doesn't even require a big incision. If we give incision, it's like half a centimeter, not even. And through that big tube in the groin, right here, under X-ray, they are putting a new valve in. Again, newer technology, but it's proven. Multiple trials, multiple studies, we know it's effective and it's very safe. So this is TAVR. Just to explain it a little bit more, so what we do is, so you see here, this is the big chamber of the heart. This is the left upper, this is the left lower. And I told you between the left lower and the aorta, that's a big vessel that supplies blood to the heart, that's where the valve was. So what we do to start with is we go from the groin, come into this big vessel, through that, that's where the original valve was. We usually put a balloon there, crack it open to make a space for the newer valve. So that's what you see right here. Here is a balloon, inflated, and that's squeezing the valve towards the walls. And then we take a newer valve, again coming through the groin, coming through this big vessel behind the heart, come into right where the aortic valve is, and we leave this new valve there. And this valve functions. No open heart surgery, and the patient gets a new valve. It's an amazing technology. Balloon aortic valvuloplasty is happening right here. And sometimes, to be honest, if patients cannot get a new valve through the groin, they could be candidates of just ballooning it. We balloon it open, and it might work for 6 months to 1 year, and then the valves start narrowing. But in some patients, it's still a treatment option. So we might do that. And then TAVR is TAVR, where we replace the valve and that valve lasts longer. So again, I will just again emphasize how it is different what we are talking about from coronary stenting. So if you can see here, so there is the left lower chamber, aortic, and that's where we are working on the valve. And after replacement, one of the valves, there are 2 currently approved valves, one of them looks like this, and there's a valve in between. The coronary artery stenting is the business with these vessels. Much smaller, but these are the ones that cause heart attack and blockages, leads to chest pain and everything. So these vessels are coronary arteries. Once we put stents in them through these holes, those are coronary artery stenting, where we put a stent in and move this plaque away and leave the stent in. So see that this is different. That's when we talk about coronary stenting, we are working on these vessels that are supplying the heart. You can see that on the surface, these little guys. That is coronary stenting. Compared to aortic valve intervention, it's much bigger valve and much bigger structure that we place in, and it's totally a different problem that we treat. But again, both are done either, like, this valve replacement is usually done through the groins or the arm. Coronary stenting is sometimes done through the groin and sometimes through the arm, right here through your hand. So that's how it's different. So these are the current 2 approved valves in United States. One is a pig, other is a cow, so you can choose, like, based on your preferences there too. And that's how they look like. One valve is here and the other one is here. Same thing, the procedure. Here is the catheter coming through the groin into the big aortic aorta, into the big vessel, going into the left lower chamber. Same thing here. We inflated the balloon, put this valve, and then removed our catheter, and the valve is there. So again, this can be done today through the groin without open heart surgery. And once you leave it, this picture keeps on coming, I know. So once you leave, this is the second type of valve, and once you leave it, that's how it looks, and it functions pretty good. What are some of the complications that you guys need to know that can happen? Leaky valve. So sometimes what we have is once we put the valve, it's different. We did not dissect the old valve out. We did not put the sutures in. It's a different technology. So sometimes there is a little bit of leakiness around the valve that remains. And there are different ways to deal with it, but this is one of the complication or problem. Sometimes we have to call Dr. Slotweiner because patients develop conduction disease, may go into heart block. So patients they pay for one, but they get both. They get the valve and the pacemaker. You know, we don't charge extra for that. So,
But the insurance company pays it.
what is it?
The insurance company will pay it.
Yeah, I guess they'll have to, but we won't charge you though. So. Okay, now. It's usually bundled, you know, so if it's a complication pacemaker, it's bundled. But anyways, that's a different discussion. So, yes, sometimes patients do get pacemakers. Stroke is a complication with both open heart surgery and this procedure. Actually, newer studies are showing that the stroke risk is lower with transcatheter than open heart surgery, actually. We are doing better there. Bleeding can happen because we are going through the groin into the blood vessels. So sometimes the control is a problem, patients can bleed, but we watch it, you know, but it can happen. And very, very rarely, God forbid, procedure-related mortality is there. The third thing, again, medications. Let's say some patients are not candidates for open heart surgery. They're not candidates for TAVR or transcatheter aortic valve replacement. They are not even candidates, some of them, for ballooning. So then all we have left is medications. Medications is Lasix. Some of you guys might know because patients tend to retain more water in the lungs. So we give them this medication to pee that water out. So they feel better. It's really symptomatic relief. It does not do, no medication does anything to the valve or treat it. It's a mechanical problem. Solution is mechanical. Either open heart surgery or preferably TAVR now, the catheter aortic valve intervention. Before I finish, so how many centers here in Queens who are doing this TAVR procedure? You guys know? One? Which one is that? Us, we are actually, so the actual answer is at this today is 0. We are not doing it yet, but at our institution we are in the process, and next actually few months we will be doing it here. So let your friends know, let everyone know that, you know, we are in the process. We are working very hard under the leadership of Dr. Slotweiner and other faculty members, putting the program together. I do it, I have done many. But the reason of me actually coming to Queens, I was trained in Queens. I did my fellowship. The reason for me to come back to Queens is I want to serve Queens community, and these are one of the few programs that I'm establishing so our patients don't have to go anywhere, and we should be able to do it right here in Queens. So that's where we are. Okay, yes.
Do they do it?
They're not in Queens, they do it.